Greetings. Let us talk about complications, especially controlling bleeding and preventing rebleeding after colon polyp resection. These are my disclosures. I have no conflicts of interest. And during the next 20 minutes, we will talk about the prevalence of complications and their impact, especially of bleeding, the role of antiplatelet drug use and antithrombotic use in patients undergoing colonoscopic polypectomy or resection, and what do you do during the procedure when you encounter a pediculated polyp or a flat lesion. How do you make the risk assessment, and what type of current will you use, and what are the benefits of applying clips? So let us start. So when you see a patient in the clinic for large polyp resection or for colon cancer screening, when you encounter polyps, you need to counsel the patient about the risks of the procedure and management of those risks. Now we have large data which amounting to over 2 million colonoscopies that shows that colonoscopy is very safe. In terms of bleeding, the risk is about 2.6 per thousand procedures, and in terms of mortality, it is very, very low. Let us look at the impact of these adverse events in patients undergoing colonoscopy. Again, a very large study of about 4 million patients. What does this study tell us? Among the three major complications, bleeding, perforation, and splenic injury, the 30-day mortality for bleeding is low compared to perforation and splenic injury. So we could safely say now, unlike in the early 70s when patients with bleeding had much worse outcome, that we could reassure patients that if bleeding were to happen, we could take care of them. The next step is you should ask the patient whether the patient is on any antithrombotic medications or on any anticoagulants, and how do we manage those risks associated with the use of those two agents. So here is a randomized control study that talks about holding clopidogrel in patients undergoing polypectomy for small lesions. You could say between 5 to 8 millimeters in size. When you look at it, in this randomized control study, one group, the clopidogrel was held, and in another group, the clopidogrel was continued, while the patients were on aspirin for the majority of the cases, almost close to 80%. What this study shows us is for small polyp resection, the risk of continuing clopidogrel is not high when you look at the risk of delayed bleeding. And we know that they can bleed immediately, but this immediate bleeding can be managed. At the same time, another important point you have to keep in mind is what is the risk of holding clopidogrel in terms of cardiothrombotic events. That is another important point we need to talk about when we are discussing this important factor, whether to hold clopidogrel or not. As you can see, there is no difference. If I have a patient that is at high risk for cardiothrombotic events, I would prefer to continue both aspirin and clopidogrel and safely cut those small polyps and manage the bleeding immediately, because nowadays we have clips to control that bleeding. How about the newer antithrombotic agents? This is a large database study, and what they have shown is the risk factors for bleeding are particularly so when patients are on warfarin and you use a bridge with heparin for the procedure. That is a risk factor. And again, patients who have a high CHAD score, patients with serious comorbid conditions, and if you do EMR, these are the risk factors. The direct acting oral anticoagulants do not show much adverse risk. So this is something to keep in mind. We don't have randomized control studies, but this is a retrospective data analysis. Another important thing is, can you continue anticoagulants in patients undergoing small polyp resection safely, so that you do not put that patient at thrombotic risk by holding the anticoagulant? So let us look at it. We have two good studies on this. And the first one is patients with less than 10 millimeters were continued on warfarin, and in one group they did cold snare polypectomy. In another group they used hot snare resection. As you can see, their mean INR is about 2.4, 2.3, and with cold snare resection versus hot snare resection, there is less risk of bleeding overall, and the procedure is faster. So, if you have a patient who has atrial fibrillation and coming for the procedure for the first time, where you expect small polyps and you think that the risk of thrombotic events are high if you stop the anticoagulation, you could talk to the patient and say, we could offer cold snare resection if the polyps are small. We don't have data for large polyps yet. Another important thing is we were in the habit of bridging with heparin for patients undergoing hot snare resection. So this study shows one group where anticoagulation was continued, again for small polyps, and underwent cold snare resection. Another group, there was a bridge to heparin and then hot snare resection. As you can see, the major bleeding was less frequent in patients who had cold snare resection while they continued the anticoagulation. So, although it looks less, basically there was not much difference between the two in terms of the procedure time and hospitalization time. It was shorter in patients with continuous anticoagulation than heparin bridge therapy. So, if you have a patient who has small polyps and they are on anticoagulation with warfarin, you could safely do cold resection. That's one thing to keep in mind. If you have a patient that is on Plavix and aspirin and you want to do cold resection, you could also safely do that. You may encounter a little bit of immediate bleeding that can be controlled with clips. So let us go to the procedure room and how to manage a pedunculated or a flat lesion. Let's talk about pedunculated polyps. And we have a lot of data. And the The big meta-analysis shows that large pediculated polyps are best managed using a combination of epinephrine following mechanical therapy with either clips or application of a loop. That has the best outcome in preventing early rebleeding. There is no effect on delayed bleeding. So let us move to flat lesions, which is a hot topic now. And there are a couple of risk score assessments, one from Spain and another from Australia. In summary, when you think about polypectomy, and if you know the patient and if you know the lesion, you could fairly come up with the risk assessment. Elderly patient with comorbid conditions, especially with the right side lesion that is large, is at a higher risk for bleeding. That's the patient you have to make sure that you are worried about bleeding and what precautions you would take to control not only the bleeding during the procedure, but prevent or limit delayed bleeding. In terms of the type of cut, some of us have grown up using forced coagulation, effect 225 watts, and some of the recent endoscopists who had recent training have come up with using endocut Q. Heiko Pohl has done this very beautiful study comparing endocut Q, effect 2, duration 1, interval 4 versus forced coagulation in a randomized control study. What they've shown is, in this large randomized study, there was no difference between major adverse events that required hospitalization between the blended cut or endocut Q with those parameters or forced coagulation. The immediate bleeding was a little bit higher in the endocut mode, but did not reach statistical significance. Again, both groups had a similar recurrence rate in polyps larger than 20 millimeters that they put in their study. So something to keep in mind, at the end of the day, when you're resecting, it is not just the current that determines the whole outcome. How you close the snare and how you use the pedal also makes a big difference. And whether, how much of saline that you use to lift the lesions. There are other parameters that would influence the outcome of these procedures. But for now, whether forced coagulation or endocut, with those parameters, there's no difference between the two groups. Say, for example, you resect and you see multiple blood vessels in the base of the resection, 3 or more vessels. According to the Australian group, this is a predictor for delayed bleeding, and maybe this is the group that you may want to consider prophylactic measures like closure. So how about when the bleeding happens during the procedure? What could you do to control the bleeding? You could use the snare tip soft coagulation, effect 4, 80 watts. That will control most of the small bleeds. And if it doesn't work, you could change to a hemostatic forceps, again 50 to 80 watts, effect 4. Again, soft coagulation. Soft coagulation because it doesn't, damage doesn't go too deep. So it tends to be superficial. Say, for example, it doesn't work, and you could also apply a clip to control the bleeding. Now let us look at how do you prevent delayed bleeding. There's a lot of data on clips. There is very little on polydocanol and peptides, but we will cover those as well. Now we have a lot of data showing that clip application is effective in preventing rebleeding after large polyp resection, especially those in the proximal colon. It doesn't show a benefit for small distal lesion resections. So that is something to keep in mind. So if you're planning to do EMR, you better learn how to apply clips nicely so as to completely close the defect. The next question comes is, clips are costly. Is it cost effective to use clips? In an interesting study looking at the cost effectiveness of clip use for Medicare patients using the Medicare costs, it does make sense when you use it in proximal lesions and large lesions. It may not pan out if you use clips for distal lesions. So now there is data to show that clips are effective, clips are cost effective. We have used polydecanol for sclerotherapy in the 80s, 90s, and early 2000s maybe. And the concept has been shown in a randomized control study that 1% polydecanol does cut down immediate and delayed bleeding. Another important facet that is coming out is the use of this self-assembling peptide, which is not available in the United States, but a lot of my colleagues from Europe are using it, and they feel that it does make sense. It is very easy to apply. You don't need the technique of clip closure, and something we need to watch for. So say, for example, you do a nice resection, close the defect, go home, everybody is happy, but some of them come back with delayed bleeding. What to do? So how do we manage delayed bleeding? So this is a beautiful study that has just come out in gastroenterology showing that it is not necessary to jump and scope every patient that comes in with delayed bleeding. About half of the patients with delayed bleeding do not require any hemostatic therapy. If they don't have any hemodynamic decompensation signs, and if it looks like the bleeding is slowing down or stopping by the number of bowel movements coming out, one could wait and watch and let the bleeding cease spontaneously. I encourage you all to study this paper that came out in gastroenterology again this year that shows that we could hold off and not jump on every patient that comes in with delayed bleeding with emergency colonoscopy. In summary, bleeding after polypectomy is uncommon and rarely fatal. Cold snare of small polyps is safe in patients on antithrombotics. Large polyp resection in the right colon, especially in elderly, increases the risk of delayed bleeding, and clips prevent bleeding, and also clips are cost effective after large right colon polyp resections. If patients come back with delayed bleeding, about half of the patients do not need emergency colonoscopy. Thank you.